I would now like to welcome you to our webinar, Fearless Empathy in Action, Responding to Suicidality and Self-Injury. My name is Amanda Lyon. I use she, they pronouns, and I'm a training and technical assistant specialist with the National Center on Domestic Violence, Trauma, and Mental Health. Today, I am presenting with Victoria Wynkoop Abrahamson. Tori, would you like to say hello and introduce yourself?
Yeah, thank you, Amanda. Hi, everyone. My name is Victoria. I go by Tori. I use she, her pronouns, and I am the Training and Technical Assistance Manager here at the National Center. And I'm also a tribal member of the Spokane tribe with kinship to the Coeur d'Alene and Colville tribes as well. Thank you all for being here today.
Thanks, Tori. Next, we'll share some troubleshooting tips about this platform. If you get disconnected from today's session at any point, please re-enter the session using the original webinar link that was emailed to you. If the sound is unclear, it's likely due to an unstable internet connection. If this happens to you, feel free to call in for a better audio connection. If you're experiencing technical difficulties, you can directly chat with Sarah Lee, also with the Center, for assistance. If you're unable to contact Sarah, please reach out directly to WebEx Tech Support. Sarah will now post that phone number in the chat box. We welcome you to use the chat feature to share your thoughts, questions, and any resources throughout the session. Your screen may look a little different depending on what kind of device you're using. Usually the chat box can be found at the bottom right of the screen. You may have to click on the chat icon that looks like a speech bubble to open it. So let's test the chat feature now. Please introduce yourself in the chat and let us know where you're joining us from today. The National Center on Domestic Violence, Trauma, and Mental Health is a special issue resource center that promotes an accessible, culturally responsive, trauma-informed approach in the domestic violence field and an accessible domestic violence, culturally responsive approach in the mental health, substance use, child welfare, and legal fields. We offer training and technical assistance, research, and evaluation. We also participate in policy development and public awareness activities. I am honored to be living and working in the unceded homelands of the Alutiiq Chugach, Supiaq, and possibly other inhabitants who lived and thrived here for thousands of years. This area was previously known as Kutashlik or Katuchik, today called Seward in Alaska. Seward's local tribal organization is called Katuchik, which serves people from diverse cultures, including Inupiat, Athabaskan, Aleut, and Alutiiq, who continue their subsistence practices, cultural traditions, and speak their languages. Our center is headquartered in Chicago, the unceded homelands of the Council of the Three Fires, the Odawa, Ojibwe, and Potawatomi nations. We invite each person to learn about the land you are connected to. And one resource to get started is the website native-land.ca. As part of our commitment to caring for each other, I want to encourage you to take care of yourself throughout this session. We will be discussing intimate partner violence, suicide, and non-suicidal self-injury. This is a space that centers on strengths, lived experiences, healing, and well-being. If at any point you need to take a break, we encourage you to take care of yourself and return when you are ready. Many of us have been affected by suicide and I want to take a moment to honor those we have lost, those who are struggling, and those who have survived and are with us today. If you wish, you can take a moment and share the name of someone you'd like to honor in the chat, their initials, or a wish for those who may be struggling today. And I'll just take a moment for that. Thank you all for sharing. I appreciate that. And again, showing us that, so many of us are affected. Thank you all so much. Numerous studies have shown that victimization by an intimate partner increases a person's risk of experiencing mental health challenges. Those affected are 3 times more likely to have post-traumatic stress disorder, major depressive disorder, or self-injury. They're 4 times more likely to have suicide attempts and 6 times more likely to have a substance use disorder. Depression, PTSD, and substance use are also associated with an elevated risk of suicide. Survivors have often lived through multiple traumatic events or abuse starting in childhood, increasing their risk for these mental health effects. This perspective is an important reminder of the impacts that trauma and abuse can have on health and well-being, especially keeping in mind that unsafe partners often undermine a survivor's mental health or may leverage mental health to increase their control. When talking with survivors, we want to hold empathy and understanding for their experiences and remember to offer support for where they are today in a way that respects their self-defined goals. Just because someone is experiencing the impacts of trauma and abuse does not necessarily mean that they need or want mental health or substance use treatment. Today we'll be talking about different aspects of suicide, suicidality, and self-injury. These are topics that have a lot of stigma associated with them. And one of the unfortunate effects of stigma is that people don't seek or receive the help they need because of their self-perceptions or the perceptions of others. Many of us experience stigma around death in general and feel uncomfortable talking about death openly and honestly. Domestic violence is another stigmatized topic, and I encourage all of you to reflect on what it took for you to become comfortable talking openly about domestic violence and how you approach this topic with others. I'm glad we're here today sharing this space because one of the most powerful ways to destigmatize a topic is to learn more about it so you can easily access some of the key language pieces. After this presentation, I encourage you to talk to a colleague and practice discussing these topics out loud if you haven't already done so in your work. This slide starts by introducing the difference between suicide and suicidality. Suicide is death caused by injuring yourself with the intent to die. This is different from suicidality, which includes the risk of suicide, which might include suicidal ideation or intent, or with a suicide plan. Suicidal ideations are when someone has persistent thoughts or preoccupation with death and suicide. These ideations can vary, meaning they are sometimes worse or at their worst and can feel overwhelming. Sometimes they are better or more manageable. There are two really important points here. First, suicidal ideations are not consistent but changing. When a person is having overwhelming suicidal ideations, that can change within an hour, overnight, or within days. We want to keep this in mind when we are supporting a survivor with suicidal ideations, that we can hold hope for them that these things will change. The second important point is that most people with suicidal ideation do not have suicide attempts. Just because someone is thinking about suicide does not mean they are going to take action towards death as a result of self-harming. Here we have a definition of self-injury: the intentional destruction of one's body tissue without suicidal intent and for purposes not socially sanctioned. Socially acceptable actions would include something like piercing or tattoos, as opposed to other actions like cutting, burning, scratching, headbanging, or hitting. We can better understand self-injury as a method of coping. Self-injury may be used to reduce feelings of loneliness, powerlessness, anger, frustration, pain, or hopelessness. Conversely, self-injury may be used to try to feel something when experiencing a sense of numbness. Unfortunately, self-injury can become a cyclical pattern with shame and guilt, or ritualized. Self-injury can also provide a sense of relief and a sense of control. Although self-injury does not include suicidal intent, it may have an association with suicide when the injury unintentionally results in death, which is again why we seek to understand and destigmatize this topic. In doing so, we reduce the burden of shame and guilt so survivors can more easily choose to access the support they wish to access. Previously, we talked about some of the intersections of intimate partner violence, mental health, suicide, and self-injury. Many of the risk factors for suicide are the same as risk factors for intimate partner violence. These include barriers to health care, such as a lack of availability or a lack of access, stigma, biased media coverage that reinforces these cycles of shame and guilt, discrimination, trauma, and abuse, especially considering the burden of the lifetime of experiences survivors have often faced, isolation or lack of social support, which is often made worse with coercive control, relationship conflict or loss, previous suicide attempts, mental health or substance use challenges, job or financial problems, which we again often see financial control and economic abuse by unsafe partners, hopelessness, and chronic pain, which many survivors experience as an effect of abuse and which may contribute to substance use as a method of seeking pain relief. And finally, we also see a family history of suicide. Despite the sometimes overwhelming challenges faced by survivors, we also want to recognize and reinforce strengths. We can do our part to build protective factors. Advocates and organizations can support effective coping skills, and we'll discuss that a little bit more later. When we hold hope for others, we can start to identify their reasons for living collaboratively. Cultural belonging is a powerful source of resilience that may be supported through community partners, providing opportunities to engage with cultural practices, and continuously listening to and uplifting diverse voices. We want to support positive relationships with survivors with their trusted friends, family, and community members, as well as opportunities for survivors to actively participate in their communities. We can support access to health care and get to know which providers in our communities offer services that are domestic violence, trauma-informed, and culturally responsive. We can support reduced access to lethal means, which could be anything used to carry out a life-threatening self-destructive act, especially within the context of someone having a short-term crisis. So let's take a few minutes to share in the chat. How do you or your organization already work to support protective factors and resilience for survivors? So again, if you wouldn't mind sharing, thinking about these protective factors, how are you working to support protective factors or resilience for survivors? I'll give you a moment to think about that. Kat says their safety planning includes the discussion of strengths. Carrie says being personalized advocacy. Annie has safety planning, counseling, and support groups. Sarah also includes coping skills and safe people in their safety plan. We also see more people saying support groups and coping skills, offering referrals to therapy, being non-judgmental. See, wonderful. Collaborations with community partners, fantastic. Looking at community groups, creating culturally safe spaces with diverse staff. See, sorry, some of them are a little too fast for me. Yes, relating to people as with your own lived experience is really powerful. Connecting clients with wraparound supports. Fantastic. So wonderful. So knowing it's so wonderful to see the work that you're already doing. And I know you're all doing so much out there. Listening to listen and not listening to respond. Beautiful. So when we think about supporting survivors who experience suicidal ideation or self-injury, we always want to think about this as an ongoing cycle. We must take time to prepare before a stressful event so that we can adequately respond during a stressful event. Once the immediate crisis has passed, we must take time for reflection and care, both for ourselves and for others who have been affected. We also want to digest and evaluate what happened to help us identify any needed policy changes, training, or new community partners. With that information, we then return to preparing. This cycle can be applied to how advocates are working with survivors, how we remain survivor-centered in our care, and how organizations support staff in difficult or stressful situations. The cycle of support was introduced in more detail in our January webinar, Building Bridges to Healing, and I encourage you to check it out if you weren't able to attend. Checking in with ourselves is an important part of preparing for a crisis response or before responding to a stressful situation. If you know you're heading into a difficult day, you may even want to start your day off by checking in with yourself. Do I have what I need to respond? What helps me to stay grounded? How do I access additional support? If I'm working alone and worried that someone is feeling suicidal, what happens if I feel like I need to respond and I haven't checked in first, and I haven't asked for any help? Does my organization encourage self-support, and how? How am I feeling, and how might that affect someone else? We want to know the difference between when I feel uncomfortable in a difficult situation and when a situation is unsafe. Sometimes the hardest thing can just be sitting with someone in distress, but that may be all that's needed. Remember, mental health is dynamic and changing, and sometimes we just need to wait it out. Often, it's our response to people experiencing mental health challenges that can determine whether survivors feel our services are trustworthy and safe. By staying grounded, we can ensure that survivors feel our caring presence. When we are ungrounded, they may feel our frustration or our fear, which can escalate or contribute to an already stressful situation. Unfortunately, when we start to feel uncomfortable or afraid, it can lead to survivors being exited from a program or referred to services they may not want, that may cause harm, or that may replicate the power and control dynamics of abuse. For example, if a survivor who is self-injures is sent to a hospital, they may be placed in an involuntary psychiatric hold. This can turn into long-term hospitalization. Here's a quote from my partner regarding their lived experience with hospitalization for suicide attempts. Once I was hospitalized, my self-determination was lost. I was completely under their control. I was not told when I would be released or what I had to do to be released. We are all here today ultimately because we care. Many of us have heard these stories of harm and wish to do our part in offering survivor-driven and meaningful support. At this time, I'm going to turn the conversation over to Tori, who will continue talking about offering support.
Thank you, Amanda, and thanks so much for going through the ACRTI integration and bringing us to the conversation around preparation. Another way that advocates can prepare for themselves and with survivors includes the introduction of the Guide for Emotional Support. And what's great about the Guide for Emotional Support is that it can be used universally with any individual and within any organization. Within the Emotional Support Plan Guide, there are 2 topics that are highlighted within it that include talking about what helps when experiencing something that's distressing or a moment of crisis, and also includes a self-directed emotional support plan. When seeking to develop a support plan, it's important to do it when we're not in crisis or the survivor that we're working with is also not in crisis. So we can start this conversation at the initial intake when we engage with survivors for the first time. And when we introduce the emotional support guide, we also want to allow the person or the survivor to choose how and when they want to answer the questions. So maybe in that initial meeting, they just want to review what's in the packet, and then they'll want to respond at a later time on their own, or when you meet at a different designated time slot. And this is because sometimes receiving so much information at the initial intake can feel overwhelming. So giving them the allowance to just take their time and go through the materials is really important. If the survivor does experience distress, this support plan can be utilized during this time to follow what they want and what they need in these moments. And afterwards, once the survivor has regrounded themselves, give them the opportunity to reflect on what was helpful and what they might want to adjust. This also gives us, the advocates, the opportunity to reflect and adjust our own support plans as well. It's also good that anytime you have the initial meeting, or if it's in passing, or any additional one-on-one meetings and group settings, that you can ask, is there anything we can do to help you feel safer and more comfortable before we begin? Next slide, please. Additional ways that advocates can prepare with survivors is having discussions around a psychiatric advance directive. A psychiatric advance directive is a legal document that documents a person's preference for future mental health treatment and allows appointment of a health proxy to interpret those preferences during a crisis. This also allows the individual to direct their care and protects their self-autonomy and sovereignty of deciding within their own choices of what they would like to do. It is also important to note that for psychiatric advance directives, that the laws around this do vary by state. So it's important to look into that for yourselves and for your organizations. But it can still provide survivor-directed guidance for care and, again, supports the self-determination for survivors. I also just want to reiterate that survivor-driven approaches is the connection and the core to advocacy work. We tend to want to control situations when we get scared or feel out of depth, but it's important to us within our advocacy to stay within that empowering stance and keep survivors in the driver's seats while we follow the lead of the survivors along within their journeys. Next slide, please. Now, these safe conversations are for when someone may be experiencing distress or a crisis. When someone is experiencing distress or crisis, there can be fear that causes people to shut down and shy away from these difficult situations. And oftentimes it's because there's pressure around saying or doing the right thing, such as asking ourselves as advocates, like, what if I don't say the right thing? Or what if I don't help them in the ways that they need? And often we want to feel in control of the situation so that something doesn't happen. And if we aren't able to control it, we may feel like we aren't good advocates or that, we're not equipped to doing this job. So I want us to watch out for within ourselves and within other staff persons to listen for those responses that make people think it's beyond their skill set. And remember that it is okay to just sit with the survivor in moments of crisis, because sitting with them is also knowing that they are alive, and sometimes that's all that's needed. And so, thinking about safe conversations, we may want to engage with these conversations when we begin seeing warning signs of suicide that could pertain to talking about wanting to die or feeling like a burden to others, feeling hopeless or feeling anxious and severely sad. There could be changes in behaviors and making plans or researching ways to die, as well as displaying extreme mood swings. So if you are seeing any of these warning signs, please remember that it is okay to directly ask about suicide. It doesn't make the situation worse. And when you are asking about their state or how they're feeling, be sure to express caring rather than giving advice. And again, sometimes just sharing space and listening without judgment is all that's needed. Next slide, please. So, when someone is experiencing distress, you can open the conversation by describing what you've noticed, plus a statement of caring, plus asking for a conversation. For example, I've noticed that you've been giving away your favorite possessions. I care about you. Could we talk? Or, I heard you talking about wanting to disappear. You're an important person to me, and I want to support you. Could we talk a little? If they don't want to speak with you as the advocate, ask if there's someone else in the organization that they would like to speak with, whether it be another staff member or potentially another survivor. I want us to lean into the practice of peer support, which was our topic of conversation from last month for the February webinar, because peer support among survivors can create a sense of community, belonging, and potentially because of shared experiences they may have. And it also can ignite a feeling of reciprocity between each other. And through opening conversation, you can ask questions directly about suicide, such as, are you thinking about hurting yourself? Or are you considering suicide? Again, it does not make the situation worse by asking about suicide, and we want to ensure that we are asking these types of questions in spaces that survivors feel physically and emotionally safe and feel as if they can share this information without being judged. Next slide. So if and when a survivor opens up, we can utilize this practice that's here on the slide in front of us. Listen, validate, and offer action and that feels possible in the moment. And while we're listening, this is an opportunity for us to use the handout for the emotional support guide that the survivor filled out either at the initial engagement meeting or somewhere along before a distressing moment happens. And we want to use this for reference to ensure that we are being guided by what they want, and we are also being guided by what they need. When we go in to think about validation, just letting them know that they're not alone and that we're there for them, and offering action that feels possible, such as practicing mind-body practice techniques. So that includes yourself with the survivor. And that could just be something as simple as taking a few deep breaths, or going for a small walk within the building. Maybe they want to sit down and like color or engage with a puzzle. Whatever is available within the setting, be sure to offer it for them. Next slide, please. When we are validating and offering things that feel possible in the moment, here's some supportive responses that we can give to the survivors. So please do invite the person to speak privately. This is to help protect their confidentiality and ensure that they feel speak giving us this information. Also be sure to show concern for their well-being and use calm and reassuring tones and body language. It's also important to communicate clearly and concisely and repeat yourself as needed, because oftentimes when we're experiencing moments of distress, we may not hear or see everything that's being given to us. And so that repetition helps ground that information and solidifies what they may need in that moment for any sort of support. We also want to emphasize protective factors. So thinking about who cares about you? What kind of support system do you have within or outside of our domestic violence services? And this is because with protective factors, it helps us understand our own recovery capital, such as social, emotional, physical. We want to move away from pathologizing language and recognize the resiliency that survivors bring to us and have within themselves. Next slide, please. When someone can't tell us what they need in moments of distress, it's really important that one staff person leads. And this one staff person should be an individual that has already built rapport with that survivor, or is someone that the survivor feels like they can trust. Again, we need to make a connection and use simple, concise language and be clear, calm, and focused. And when people consider what they want from themselves, either in that moment or through the utilization of the emotional support guide, do not challenge those beliefs, because by challenging those beliefs, we're removing that self-autonomy and that respect of allowing the survivor to choose what feels right to them. So ensure to continue to create spaces that are collaborative and always offer choices. And also be sure to take your time, as if you have all the time in the world, because we want the survivors to be able to feel like they can work through and process their emotions without feeling like we're being rushed or feeling like there's something that needs to be done in the moment and is something that we cannot revisit at a later time. Next slide. So this ties into barriers of establishing emotional safety. Again, there may be a lot of fear engaging with someone who's experiencing moments of distress, moments of suicidality, or who aren't quite sure what they're experiencing. And so, with that, there may be attempts to create a speedy resolution, but I want us to slow down and think about how to help the survivor process this information, because we don't want to take it and just put a band-aid over it and not address potential long-term consequences that may come with that. And also, we don't want to have any sort of means that sound like we're giving threats of punishment or imposing a solution, such as, if you're not able to gather yourself within the next hour or so, we're going to have to ask you to leave our services. Or if you don't quiet down, we're going to have to ask you to leave the building. These threats of punishment and imposing these types of solutions aren't helpful for the safety or the well-being of the survivor, because, again, we're not listening or considering what the people want for themselves. This also indicates that we may be feeling uncomfortable, where the situation may not actually be a crisis, but there could be an opportunity to bring the person into a private area and speak with them so that they're able to talk to us about what they need. Next slide, please. So ways that organizations can prepare, having clear policies that staff can access and implement. These policies should not be fear-based or based on worst case scenario or based on a one-time occurrence that was difficult to manage. We want to ask ourselves if the policies feel accessible to staff. Do staff know how to implement the policies that exist, such as clear policies that people can act on? And nobody has to, do anything hard that feels maybe like they're doing it alone. And so what do you do if you're alone as a staff person? And so within the policies, it should be easy to find. It should be effective, even within a worst case scenario. And being able to offer support so that no one feels alone. And asking yourselves how to get support from other staff members, community partners, peers, helplines, potentially other community sources. And we want to ensure that these policies and actions are always survivor-led and focused on the support without replicating those power and control dynamics because of a fear-based response. Next slide, please. Additional ways that organizations can support policy work around emotional crisis and distress is thinking about policies that emphasize harm reduction techniques for self-injury. So this can include doing role plays and other practices to build confidence. So practicing the conversation starters in the slide deck, thinking about the availability of what you might have on the ground for first aid kits, and or looking at the emotional support guide. By doing these role plays, it's important to say these words out loud, because there are a lot of these words like suicide that are really hard to say out loud. Additional supports include ongoing training and understanding Good Samaritan laws. And with Good Samaritan laws, understanding what the mandated reporting requirements and these laws inquire in your state and how they might be applied to staff or partners that are utilizing your services. Other ways that organizations can support is through supervision, group debriefing, evaluation, and integration of feedback. And additionally, again, the development of community partnerships. Next slide. With the development of community partnerships and thinking about outside support, a survivor may find it helpful to talk with an advocate about the potential risks and benefits of disclosing their information to responders. So advocates can also help with safety planning around any potential risks involved if a survivor chooses to disclose the information to responders. For example, safety planning around the potential risk of insurance notices being sent to an address that could alert an abusive partner to a survivor's whereabouts. If a conscious survivor is experiencing a significant trauma response where staff believe emergency services need to be called, but a survivor has not requested or is not interested in emergency responders, here are a few things to consider. The first is asking ourselves, is it a true crisis? Is someone in imminent danger of or already has harmed themselves or someone else? Or program staff feeling uncomfortable and not sure what to do? For example, if someone's being loud or yelling, it's not a crisis, but can certainly make some people feel uncomfortable. And so those are instances where you would want to create that environment of safety and finding ways to make that connection with the survivor. And when thinking about harm reduction practices, especially if there is a self-injury that isn't life-threatening, we want to ask ourselves again, what kind of first aid options do you have in-house? And providing training on trauma-informed crisis support can help minimize unnecessary use of emergency responders. And so I just want to very quickly ask, what are other alternative resources that exist within your community, whether that's in person or virtually? I see religious supports and leaders. Yeah. A living room program. That's another one. Yeah. Tribal support groups, 24-hour mental health associations, crisis lines, warm lines. Yeah, these are all great examples. So again, some examples do include hotlines, text or chat support, peer-based support, living room programs, which are effective alternative to emergency rooms for mental health crises. And all confidentiality rights remain in place with these alternative resources, but they can further help maintain a survivor's confidentiality when they don't want or need emergency responders involved in their mental health support. I also encourage you to see our online tech safety resources for more information on enhancing confidentiality and privacy protections when accessing tech-based support. Next slide, please. So up to this point, we've focused on the preparation stage and responses during a crisis within this ACRTI integration framework. So after a distressing event has happened, we can move further along in this framework by exploring reflection and evaluation. So reflection, after a stressful event, check in with yourself and the person you've been supporting. How did it go? What could have gone better? What does ongoing support look like for both of us? What do I need right now? How do you care for yourself after a stressful situation? And how do I think it went? And we can also check in with ourselves and ask what went well and what could have gone better. What do we both need? And to ensure that as staff and as advocates, debrief with colleagues or supervisors in a timely manner, which should also be included within policies and practices. So thinking about what else is needed and moving forward and how we can continuously update and change environments, interactions, safe partners that we can collaborate with, and additional resources. We could also look at evaluation, again, for reviewing and updating our own safety plans and the safety plans of the survivor, and then updating any sort of warning signs or coping strategies within ourselves, and potentially what survivors notice within themselves too. And always having continuous and updated connections to training and resources, and again, updating policies as needed. Next slide, please. So this is a quote that was shared with us in one of the research surveys that we've done through the center. And it's a survivor perspective when they've experienced mental health distress or crisis. And they say, when I am in crisis, I need people who can be with me when I'm in distress, be present with me when I'm in pain, who will acknowledge my pain without trying to fix it. This takes someone who knows their pain and is not afraid of it or yours. Next slide, please. So thank you all again for coming to today's webinar session. These next two slides share my contact information and Amanda's contact information. We can also put our emails in the group chats. I also very quickly wanted to share that we also have our upcoming webinar series for April and May and June. So again, feel free to check out our whole series within our webinar library. Other resources through the center include our guide for emotional support and Survivor Health Connections, Increasing Access to Desired Resources, which is a webpage with materials designed to increase survivors' access to resources that support their safety and well-being. Other resources that we have is our ACRTI core curriculum, specifically within Module 6, that offers an ACRTI approach working with survivors experiencing emotional distress, mental health crisis, and psychiatric disabilities. And with that is a handout included for practical strategies for understanding and supporting someone who self-injures. For webinar resources, we have trauma-informed responses to emotional distress and crisis, and then a 5-part webinar series that looks at supporting materials on mind-body practices and trauma-informed crisis support. We also have this guide that looks at recommendations for suicide prevention hotlines on responding to intimate partner violence, and more webinars that look at change leadership and supervision using reflection to support both staff and sustainable change, and our tip sheet that's a reflection tip sheet to enhance supervisory practice within domestic and sexual violence programs. Outside additional resources include Coping with Self-Harm, a guide for parents and carers, the Suicide Prevention Resource Center, and the National Resource Center on Psychiatric Advanced Directives. We also have the 988 Suicide and Crisis Helpline, a SAMHSA publication that is a journey toward health and hope, your handbook for recovery after a suicide attempt, and Now Matters Now, a website sharing stories and research-based ways for managing the most painful moments of life. And if you're looking for additional resources, please feel free to visit our website here. And we also have our own newsletter that you can sign up to. And if you want, you can follow us on our social media handles that are for Twitter, Instagram, and Facebook. We now open it up to any sort of questions or comments that you may have for today's session.
I know I saw one question come up in the chat that was asking if suicide contracts are recommended. So when someone sets an agreement with a therapist, essentially to not practice suicide. And my perspective, initially thinking about this, would be that potentially it could reinforce someone's experiences internally of guilt and shame around how they're feeling, and cause them to not seek help when they need it. So that would be my personal concern. Um, and I'm wondering if Tori, if you had any thoughts as well.
Well, I definitely think I'm on the same page with you of the hesitation of how it may bring up more feelings of guilt and shame. So, um, I do see another question in the chat that asks, what do we do if an older adult is suicidal and we report it to APS and the family, but they choose not to act?
I think it depends on what your relationship is with this person. Um, yeah, so if they are someone who that is in services with you, yeah, APS might not have anything to do. So I would say it's essentially kind of the same, figuring out like what this person would like for support, how you can offer that support, offer what is reasonable, and see if maybe there are other resources in the area that they can connect with. Yeah.
It's also important to keep in mind that while making these outside referrals, to have continuous collaboration with these partnerships to ensure that you both have an alignment between your missions and value statements. Um, Mainly because there there are times when services can produce more harm than it can good, and there could be potential reason why there's resistance to reach out to other services rather than your own. So really having those initial conversations and building that rapport to ensure that you're having an understanding of what feels right for the survivor when they need access or help to additional resources and services.
And let's say I also see how do we respond when we bring up the question and they get mad, lash out, or deny it when it's clear there's something going on. I think, again, the best thing that we can do in those situations is to continue to focus on our positive relationship building with those people so they start to feel that it is safe to trust us with whatever is going on with them. And as Tori mentioned earlier, to ask them if there's someone else that they would like to talk to. Maybe there's another survivor or another staff member where they would feel more comfortable. We want to stay survivor led and just do the best we can to, again, let people know, like, hey, I am here. I am a safe person. Um, I'm still here to listen if you ever change your mind and you ever want to talk about it. So it's okay if you don't want to talk right now. But we want to have that non-judgmental, compassionate, grounded approach, and to always recognize that when someone does kind of lash out or get angry, that to not take it personally, right? That to remember that it's not about us or anything that we necessarily did, but to try to just hold that space, just like, okay, see you're upset, but I'm still here.
We have another question that asks, how do we offer support to minor clients if guardian is abusive and child protective services won't act? And for me personally, there's a couple things that come to mind. The first is, again, understanding the roles of these other services and the ways that they can provide supports. And also reflecting back on what we can control and what we can't control. We can't control what other services or other programs do to provide additional support. So that's where the emotional support planning or even safety planning can come into play when working with survivors or youth who are survivors of domestic violence, so that there is at least something that the the survivor can refer back to in these moments of needs, and as well as understanding that you are a safe space to come to talk about other potential resources or other sort of options when they're experiencing distressing moments. Do you have any thoughts, Amanda?
Yeah, I would say, if it's not your specialty, to work, if you're not, working with minors, but this is a situation that's coming up, to again look for other partners, or even, national, like love is respect, and be like, okay, asking for support there. Um, but yeah, I agree with what you've brought up, Tori.
And then we have another question that asks, what can school social workers do to best inform students about reporting, preparing them for what reporting entails? And right off the top of my head, my first thought is just transparency, just letting them know what that process looks like step by step so that there are no surprises for them.
Yeah, completely agree. Letting, um, just like that's what we'd want to do with anybody with reporting. We always want to include them in the process and let them know what's happening, give them the opportunity to be there as the within the reporting process rather than reporting for them whenever possible.
Yeah, and by having this high level of transparency, it also lets them know, or gives them the opportunity to decide whether or not it feels safe to disclose certain information or not as well. And so again, giving back their autonomy and self-right to choose. Um, Another question that I see is, are you licensed therapist or psychologist? I am not. I'm a trained counselor. I'm wondering if therapists are required to refer suicidal clients to a hospital as a part of their requirements by their governing boards. And again, I believe that would be dependent and varying state by state. So you would want to check in within the state that you're in and look up those laws and regulations for reports like that.
And we definitely encourage people to build relationships with providers in your area and really get to know what are their confidentiality practices, what are their reporting practices, so that it's not a surprise when we refer someone to services or try to make those kinds of connections. But yeah, they definitely will have a variability.
I'm not seeing any more questions in the chat, so I'm going to go ahead and turn it back over to you, Amanda, for our closing out.